Hello everyone, I'm really excited to be sitting here with Dr. Dale Bredesen, who is internationally recognized for his understanding of the mechanisms of neurodegenerative disease, particularly Alzheimer's disease. He holds faculty positions at University of California, Los Angeles and the Buck Institute for Research on Aging. In fact, he was the founding president and CEO of the Buck Institute back in 1998. So that's really kind of cool. And he also is an author of a New York Times best-selling book called The End of Alzheimer's Disease, which I'm sure we're going to talk quite a bit about today. He's got a really interesting multi-pronged protocol for preventing and also helping treat mild cognitive dementia and Alzheimer's disease. So thank you so much, Dale, for having me here at your place.
Thanks very much, Rhonda.
So maybe we can start a little bit by just talking about some of the characteristics and pathological distinguishing features of Alzheimer's disease, and maybe what your thoughts are on what can cause Alzheimer's disease, what leads to it.
Right. So it's a good point because cognitive decline, very common, and Alzheimer's is the most common cause of cognitive decline, ultimately dementia. And by definition, this means that you have amyloid plaques in the brain and phosphorylated tau tangles. So those are the two main pathological hallmarks of Alzheimer's. But as you can see, that doesn't tell you why you got it. It just is something you look at the brain. And of course, you can get something that looks virtually identical without the amyloid. And you can get amyloid without the cognitive decline. So it's a marker, but it's an imperfect one.
Yeah, that's a really good point you brought up. And do you have any, thoughts on why, there are some people that do have amyloid plaques in their brain that aren't demented, and then some others that just don't seem to handle it?
Yeah, it's a great point. So here's the thing, that the whole world is turning upside down now when it comes to our understanding of Alzheimer's. It's been over 100 years, of course, going back to Alois Alzheimer's publications back in 1906 and 1907. And there hasn't been a good understanding of this disease. And of course, amyloid has been for years vilified. And there's no question, it is a neurotoxin. It does have toxic effects. The surprise has been that this is also a protectant. It's actually something that is made by your brain when you have specific insults. And for example, Professor Rudy Tanzi and Professor Robert Moyer at Harvard a few years ago showed that it is an antimicrobial. It also, as Professor Ashley Bush showed a number of years ago, it's actually quite a good binder of divalent metals like copper and zinc and things like that, iron. And we showed a number of years ago, it is also a response to a reduction in trophic support. So you actually get a change in signaling. So there are multiple different insults and metabolic changes that lead the brain to produce this stuff. And so I think there's been confusion because it's clear that when you produce it, you're at this increased risk for having a degenerative process. But as you indicated, there are many people that produce it and they successfully are protecting themselves. They don't actually have the downsizing. What's often been stated is those who then have inflammation on top of that seem to be the ones that do worse. And that's a very general idea, but really it is a set of things. And we identified and published a number of years ago 36 different factors that all contribute to this, but they actually break down into just a couple categories. So any sort of pathogens, anything that's giving you inflammation, whether you have it because you have a leaky gut, or because you have P. gingivalis in your brain, or because you have Borrelia of Lyme disease, or you've been exposed to specific fungi, things like that. All of these things can engender that response. And in fact, we think more and more of amyloid as being like napalm. You got the bad guys coming across the border, so you're now going to put down stuff that kills the bad guys, the napalm. But in so doing, you're now going to reduce your arable soil. You're now living in a smaller country, and that's exactly what's going on in the brain. You are downsizing the overall network. So that's what we call type 1 or inflammatory or hot Alzheimer's. And I should mention, it turns out Ayurvedic physicians from thousands of years ago recognized dementia that was related to something that was hot, that was abnormal, ultimately inflammatory, as well as that was related to dryness, which is what we call type 2, where you have decreased trophic support. It can be nerve growth factor, brain-derived neurotrophic factor, estradiol, testosterone, pregnenolone, progesterone, thyroid, vitamin D. All these things are critical to support of synaptogenesis. So we think of the signaling as being a ratio of synaptoblastic activity, where you're actually sending signals to make and store synapses, just like you think of osteoblastic activity, versus synaptoclastic activity, where you're actively pulling back and you're reorganizing. And of course, this is going on all the time. You're actively forgetting the seventh song that played on the radio on the way to work yesterday, and you're actively forgetting a lot. But you're remembering the key things, like where your keys are and where your son is and all that sort of stuff. And so there is a change in that ratio in Alzheimer's disease because of type 1 with inflammation, or type 2, which we call atrophic or cold, because you don't have the support for those synapses. So you're literally, it's a little bit like someone saying, I've got 5 children and I can only feed 4. I can either watch all 5 starve slowly, or I can put 1 in a foster home and feed 4. And that's basically the downsizing that's happening when you cannot support the neural network that you have. And then we have a type that's actually type 1.5, which is glycotoxic. And we named it that because it has features of both type 1 inflammatory and type 2 atrophic. So what happens is you develop insulin resistance, so you now have a change in signaling that actually occurs because of this chronic high insulin. So you actually phosphorylate your IRS1, as showed very nicely by Professor Ed Getzel over at UCSF. So you change the ratio of the serine-threonine phosphorylation to the tyrosine phosphorylation, and you're literally changing your response to insulin. So that gives you the type 2, because you no longer have insulin as the supportive trophic factor to the extent it was previously. But of course, you're also glycating proteins with, and we measure this, of course, as hemoglobin A1C, but you're glycating many proteins. So you get now a response to that as well. So you have an inflammation and an atrophic, and so that's why it's 1.5. And then type 3 turns out to be completely different, and that is a response to toxins. So there is a toxic form, which we call toxic or viral Alzheimer's disease. In addition, there are people we call type 4 who have more of a vascular component, and then type 5, which is more of a traumatic component. But they're really both related to these other ones. It's really about, do you have inflammation? Are you fighting something off? Do you have trophic support? And are you exposed to specific toxins?
Wow. And so, and all of these different types of subtypes of Alzheimer's disease, they all sort of have some of the same distinguishing pathological features like amyloid-beta plaques, tau tangles.
Right.
Between all of them?
So they all have amyloid plaques. They all have, by definition, tau tangles. But the presentation can be different. Now, there are some overlaps. The type 1s and the type 2s are typically amnestic presentations, more common with ApoE4. And that's true for the type 1.5s as well. The type 3s, the toxic ones, are quite different. They often present with a non-amnestic presentation. It's executive dysfunction, problems with calculation, problems with visual perception, problems with word finding, so-called primary progressive aphasia. All of these things, they are really biparietal presentations as opposed to bitemporal presentations, essentially. So these are what have often been called cortical presentations, which have been noted for years by people like Professor Mario Mendez to be typical in younger presentations of Alzheimer's, and often in ApoE4 negative individuals.
I think I also read one in your paper where you did this metabolic profiling. There was very prominent zinc deficiency in that.
Yes. So for reasons that we don't entirely understand yet, many of the people with the type 3, the toxic subtype, have low serum zinc, high copper-zinc ratios, and low triglycerides. The low triglycerides may turn out to be related to malabsorption. We don't know for sure yet. But we don't really understand why the people often have these low copper-zinc ratios.
What does that mean, the copper-zinc ratio? What is that?
The high copper-zinc ratio, low zinc.
Low zinc, yeah.
Yeah, so as you know, copper and zinc actually are competitive, for example, in their absorption. And so too much of one actually is often associated with too little of another. And typically in our society, as you know, most of us are deficient in zinc. There are actually about 1 billion people on Earth is the estimate for zinc deficiency. It's a very common problem because if you have poor gastric acidity, which is common as we age, if you're taking PPIs for GERD, if you're taking something for reflux, you won't absorb the zinc very well. If you have copper piping, which most of us do, the copper will often compete with the zinc. And so many people have a little too much copper and a little bit too little zinc. And in fact, it was noted over 30 years ago that people with high copper-zinc ratios tended to have dementia more than those with normal copper-zinc ratios.
Wow. So does this have something to do with it? I know there's like over 300 or 500 different enzymes in the body that require zinc.
Right.
So does copper then bind to those enzymes and then sort of mess up the function, or is that like the theory?
So no, the theory is that copper, as you know, copper is a generator of free radicals. It is, copper can act like iron in that sense. It has a free electron in the d orbital, which does not occur with zinc. So in general, as you indicated, in these various enzymes, and it's hundreds, just as you said, it is an important structural component, and it has a very specific architecture with the enzymes that it serves. So it is a structural thing in general. And copper, to my knowledge, doesn't actually replace that. But for example, zinc is important in many things that are related to cognitive decline. It's important in diabetes. It's important in functioning of insulin. Right. It's important, of course, in the trophic activity of insulin, and on and on. It's important in immune responses. So it actually has many effects that are related to cognition.
So it may even just be a biomarker for something underlying going on, right, in the toxic insult type of Alzheimer's disease you're talking about.
It's something to keep in mind when you see that, and especially if the person presents. These people tend to be very distinctive, the people who have type 3. So they tend to be young, and we see them in their late 40s, mid 50s very commonly. We've seen them as late as starting their first symptoms in the mid 60s, but typically their first symptoms are occurring in the 40s and 50s. They are often women. They are often ApoE4 negative, although not always. There are certainly people who are ApoE4 positive who have this. As you mentioned, they often have the low zinc, and then they typically present in a non-amnestic way. Interestingly, unless they are homozygous for E4, in which case they do present typically with an amnestic presentation. But the ones who are E4 negative typically present with problems, as I mentioned earlier, executive dysfunction. So I always ask people, are you having trouble organizing things? We had one person, for example, who was known for her tremendous organizing capability, and as she started to get the problem, she just lost that. She could not organize things that she could do before. It's a very common complaint. Or, as I said, people will say, oh, I can't calculate a tip anymore. Or I can't pay the bills anymore. Anything that is math related, or visual perception, or word finding, things like that.
You mentioned the ApoE4 a few times. Can you talk a little bit about, just for people listening and watching, what ApoE4 is, and it's a gene, right? And so why it plays a major role in Alzheimer's disease?
Yeah. So apolipoprotein E is a really fascinating story, and of course, Professor Robert Maley discovered this decades ago, and it has turned out to be the most important genetic risk factor for Alzheimer's disease. 75 million Americans have a single copy of ApoE4. And when I say that, what I mean by that is everybody has 2 copies of either 2, 3, or 4. And the most common one is ApoE3. So it's common for people to be a 3-3 as an example. However, about a quarter of the population, so about 75 million Americans, have 1 copy of ApoE4. And that's actually the primordial one. It's the one that was present for about 96% of hominid evolution. If you look at a chimp, for example, it does not have ApoE4, but the hominids do, and still about 25% of the population today. Then about 7 million Americans have 2 copies, so they're homozygous for ApoE4. Now, if you have 0 copies, so if you're, for example, a 3-3, your overall lifetime risk for Alzheimer's is about 9%. So not terribly common disease, but not 0. On the other hand, if you have a single copy of ApoE4, your lifetime risk is about 30% or so. If you have 2 copies, if you're homozygous, your lifetime risk is over 50%, and in some studies as high as 90%. So most likely you will get it. And of course, the vast majority of people don't know. Now, in the past, people said, don't check because there's nothing you can do about it. And that has completely changed. So there is a tremendous amount. And the reality is, Alzheimer's should be a rare disease. It should essentially decrease to a very low level with the current generation. If everybody gets checked, we recommend that everybody 45 or over get a cognoscopy. It's a silly term, but it's easy to remember. Like everybody knows when you hit 50, you should get a colonoscopy. If you hit 45 or over, you should be getting a cognoscopy. You should be doing some testing and see where you stand. What are your risk factors? Are you ApoE4 positive? Do you have high homocysteine, methylation issues, inflammatory issues, nutrient issues, toxin issues, all these things, because they can all be addressed. And we can decrease the overall global burden of dementia.
So there's a variety of biomarkers that you're suggesting
Yes.
people can go and get measured.
Yes.
To this, what did you call it? The
Cognoscopy.
Cognoscopy, yes,
Yeah,
that's a nice term. Including the genetic factor ApoE4, seeing if they're ApoE4, and then you have a variety of biomarkers that you kind of just mentioned. Some of those I think you also have published on before, talking about the insulin sensitivity as well,
Right.
looking at insulin sensitivity and glycated hemoglobin.
Right.
So maybe we can talk a little bit about some of those biomarkers and how.
Sure.
So you have this wonderful protocol. Let's see, the MEND protocol.
Right, so it's now called ReCODE. So MEND was the very first edition. That was metabolic enhancement for neurodegeneration. But as we have, we've made 2.0 and 3.0, and we have made it more sophisticated, as I mentioned in the book. It's become ReCODE, which is for reversal of cognitive decline. And we now have over 3,000 people who are on this protocol with unprecedented, and we've published a number of the results. We actually have another thing that's just finishing up that reports another 50 people who have shown improvement.
50, wow.
Documented,
So the publications that I had read, you had shown, I think there was about 10.
There was 10, and then there were another 10.
Another 10.
Different 10, yeah.
Right, and you showed that you were able to basically take a person and that had Alzheimer's disease. Some of them had to leave work because of their issues.
Right.
You put them on a protocol, and they were not only were able to, some of them return to work, but they also seemed to have brain mass returning, and just so it was really phenomenal. So some of the very complex diet lifestyle intervention that you did here. Maybe we can talk about some of the key ones.
Sure.
Starting with like this diet overhaul.
Yeah, and I should say, it goes back to one very simple principle. We've been trying to treat this disease without knowing what causes it. So I usually tell people it's as if you took your car into the mechanic because it wasn't working well, and the mechanic said, "Oh, Rhonda, no problem. This is called car not working syndrome, and your car's going to die." And you said, "Well, wait a minute. I mean, shouldn't you figure out why something? What went wrong with it?" And I said, "Well, no. The testing isn't reimbursed, so we're not going to do that." And that's the unfortunate situation we've been in. People say, "We don't know what causes it. There's nothing to do about it. There's nothing we can do, and you're going to die." Mm-hmm. And medicine is changing in the 21st century, as you know. It is becoming less about monotherapeutics and more about programmatics. And at the center of this is to understand why complex chronic illnesses occurred. When you have something like there's a simple illness like pneumococcal pneumonia, you find the pneumococcus, you treat the pneumococcus, and all the other underlying things alcohol, diabetes, anything that could have been contributing is less important because you got at the pneumococcal pneumonia. That's not the case with complex chronic illnesses. With Alzheimer's, there are dozens of things that can be contributing. And so what we want to do is address all of those. Yes, if you have pathogens, many people have, for example, Borrelia from Lyme disease, or a Lyme co-infection like Bartonella or Babesia or Ehrlichia, things like that, then those need to be addressed. And of course, you need to change the underlying biochemistry. So as you indicated, there are specific biomarkers. So we want to know your HSCRP. It's a marker of inflammation, of course. We want to know your homocysteine, a marker of methylation. If you're not methylating appropriately and your homocysteine is high, then you are at increased risk for neurodegeneration. And of course, it's been published that you have a more rapid decline in your cerebral gray matter volume and hippocampal volume if you have a high homocysteine.
Is that because of vascular reasons, or what's the homocysteine?
Well, the publication did not distinguish. It just simply followed people over years and looked at the rapidity of the decline in volume and could show that not only was it more rapid, literally you could put the rapidity of it on a graph with homocysteine and it fit very nicely. But then if you improved the homocysteine and brought it back to normal, and they were looking at less than 7 as being normal, not less than 13, which is often used in labs, 7 as being normal. Then in fact, what happened was people actually stopped their decline and leveled off. So it suggested that this is a causal relationship, that it is a mediator of cognitive, of change in cerebral volume as well as
independent of other biomarkers?
Independent of other biomarkers, yes.
Wow.
So we want to know that. We want to know whether you have glycotoxicity. So we want to know what is your fasting insulin. And again, people will accept it way off the scale. We have an unfortunate situation where classically we have accepted laboratory values as within normal limits, W and L, very arbitrarily as being within 2 standard deviations of the mean. That actually makes no sense physiologically. It just says that there's a distribution there. It doesn't say that that's optimal for your health. So we'd like to know what your fasting insulin is, and optimally it would be less than 5 or less than 5. Although, again, within normal limits goes much higher than that. We'd like to know your hemoglobin A1C, which again is a marker of your essentially over the last 2 months, your serum glucose. We'd like to know your fasting glucose. These 3 actually give you quite complementary pieces of information, all related to this type 1.5 that I mentioned, the glycotoxic type. And then the atrophic, as you can imagine, there are lots of things. We want to know your vitamin D, and we want to see that it's optimal, not suboptimal, but within normal limits. We want to know your pregnenolone, progesterone, estradiol, testosterone, free T3. Now we'd like to know your brain-derived neurotrophic factor and your NGF. There's no simple way on a clinical lab test today to get those. So you have to infer them from other things. What is your hippocampal volume? What have you been doing? If you change these various things we've been talking about, you're likely to have a decrease. Have you been exercising? If you're not exercising, your BDNF is likely to be lower. So we want to look at all of the trophic support for your brain, because these are critical things. If you're going to make and keep a large network of synapses, you need to have that support. And again, that balance changes for many of us as we age, especially if we are ApoE4 positive. ApoE4 gives you an advantage in that you have a hair trigger, essentially, for inflammation. You are responding. So if you live in a squalid environment like the Chimane Indians that Professor Tuck Finch studied, for example, or the Ghana tribe that Tuck also has studied, you are in better shape if you're ApoE4 positive. But if you're not living in a pro-inflammatory, in an environment that's parasitic, then in fact you have this chronic inflammation that again, good for when you're fighting things, good for if you step on a nail, good for situations that should be pro-inflammatory, but in the long run, counterproductive. As you know, this is so-called antagonistic pleiotropy. This is something that can help you when you're young, but actually can put you at risk for diseases that will shorten your lifespan. And typically, cerebrovascular disease, of course, Alzheimer's disease. And as you know, ApoE4 is actually underrepresented in centenarians. So it has been a shortgevity gene, as it were. Again, that is changing. And can change by understanding what's actually being driven by this. So we want to know all those markers, and those for the type 2. And then, of course, we want to know the markers for type 3. So we want to know if there are specific toxins, and especially mycotoxins. So the toxins can be metallotoxins, like mercury, relatively common one. They can be organic toxins, like DDE, things like that. They can be biotoxins, like trichothecenes, ochratoxin A, aflatoxin, gliotoxin. These are toxins produced by various mold species like Stachybotrys and Aspergillus and Penicillium, which are literally fighting us. I mean, they're literally saying, okay, I'm fighting back. And for example, one of the responses has been when you have mold growing on treated wood, they're recognizing something's changed. Mold that have been treated with fungicide. So these are things where, just as we're seeing increasingly bacteria that are antibiotic resistant, as Professor Shoemaker has pointed out, Dr. Richie Shoemaker, who's done so much work over the years on mold and mycotoxins, and described what he calls CIRS, chronic inflammatory response syndrome. As we've had fungicides, as we've had buildings with leaks where we haven't recognized the danger from these. In fact, we've had more and more of this mold-related illness. So we want to know all those things for the type 3s. And then, of course, we also want to know, do you have a history of head trauma? We want to know if you have vascular compromise. All of those things are critical. Now, you mentioned the diet. So yes, we want to start with the basics. But again, ultimately, it's a program that is customized to you based on what's actually causing your cognitive decline or your risk for cognitive decline. And so the nutritional part we call KetoFlex 12/3, and it's for a very simple reason. So keto, so we want people to be in mild ketosis because that actually turns out to work better for cognition, and many people do better with their cognitive decline, just as Mary Newport showed, of course, with using coconut oil. And that may or may not be the best way to do it for some people. Other people like caprylic acid, MCT oil. Other people are very good at generating endogenous ketones, which, if you can do it, is the best way to do it. So we want to drive you into mild ketosis, which means a very low carbohydrate, high fat, good fats diet, things like avocados and nuts and seeds and things like that. And there is a caveat for people who are ApoE4 and a caveat for people who have very low BMI, so we can talk about that. The next piece is flexitarian. So you can be a meat eater or not. In general, we see meat as a condiment, but again, as we evolved, we tended to eat relatively small amounts of meat. But that's fine. If it's going to be chicken, it should be pastured chicken. If it's going to be beef, it should be grass-fed beef. Going to have fish, great. Make sure it's wild-caught, not farmed fish. You don't want to have the fish with high mercury. Those are the large-mouthed, long-lived fish, tuna, shark, swordfish, things like that. You want to stay away from those because they can contribute to your cognitive decline. In fact, one of the people who called me a couple of years ago was a very successful businessman who had early Alzheimer's, had already had PET scan proven, and they told him, come back in a year because you're not doing that badly yet. You're still in the MCI phase, but you could already see the signature of Alzheimer's on his PET scan. And when I listened to his story, I said, you've got type 3 and you need to find out if you've got exposure to any toxins. And he said, no, everything's great. Well, it turned out that he was eating large amounts of tuna sushi. and he happened to be genetically a poor excreter of mercury, also happened to have some dental amalgams. So he had extremely high organic mercury from the seafood, extremely high inorganic mercury from the amalgams, and then as well as, so he had the perfect storm. And his mercury was actually 7 times the 95th percentile for our country. Just massive, massive mercury exposure. And he's done well with removing that. So we want to know those specific ones. And again, for fish, you want to think about the smash fish. And my wife, who's a family practitioner, reminds me about this. Salmon, mackerel, anchovies, sardines, and herring. And she's a real expert on the nutritional side and on the integrative medicine side. She told me 25 years ago, whatever you guys come up with in the lab, in your test tube, I spent my whole career looking at what is driving the molecular signaling that leads to neurodegeneration. She said, whatever you come up with, it's going to have something to do with, what you're eating and your exercise. And I said, no, it's going to be one domain of one molecule, and we're going to get a drug for that thing, and it's going to be over. And of course, I should have listened to her 25 years ago, but she was right. It does have to do with programmatics, not monotherapeutics. So then the 12-3 part of KetoFlex 12-3, a minimum of 12-hour fast between when you finish dinner and when you start breakfast or brunch or lunch. If you are ApoE4 positive, you're actually a better fat absorber, as you know. So you want to make that 14 to 16 hours. If you're ApoE4 negative, 12 to 14 hours. And be careful, if you have a very low BMI, you can lose weight on this KetoFlex 12-3 diet. And so you have to liberalize typically once a week, have some sweet potatoes or something that's a little more carbohydrate related. And of course, in the book, we talk about the various things that you want to do with this diet. But 12 hours, that gives you time for autophagy. It gives you time essentially at night to induce your ketosis, to clean out your brain. Of course, the lymphatic system, you actually have a change in the architecture of your brain as you're sleeping. You're actually essentially sweeping this stuff out. It's kind of amazing, actually. And so if you're eating with these very small windows of sleep and very small windows of fasting, you're actually doing yourself harm and putting yourself at greater risk. And then similarly, you want 3 hours before bed after you finish your dinner. You don't want to eat right up until bedtime because your insulin's high. And again, that's hurting your cognition. That's, again, giving you the same sort of insulin resistance problem, storing fat. You're doing all the things that are not helpful. So that's the dietary approach. And of course, you want to have organic. There are toxins in our food. It's unfortunate. We've got a tremendous lifelong exposure to toxins. Of course, Bruce Ames, with whom you trained, developed the Ames test, which allows us now to look at carcinogens. But nobody has ever told us, well, hey, what about dementogens? You're exposed every day to various dementogens, things like mercury, things like some of the organics that are in some of the health and beauty aids, and things like biotoxins. If you're living in a home that has leaks, you are exposed to dementogens, and you need to know about that. So that's the KetoFlex 12-3. We want it to be, it's a plant-rich diet. Mark Hyman called plant-rich as opposed to plant-based, but either way, it is a plant-rich diet that can use some animal products. It's up to you. You want to be vegetarian, that's fine. You don't, that's fine too. That minimizes the toxins. You want to have a high, typically 70% or so calories from fat. And you can start out with using things like MCT oil or coconut oil to get your ketones up. We're finding that people who have higher ketone levels, 1.5 millimolar to 4 millimolar beta hydroxybutyrate, tend to do better than those who are down lower.
ApoE4 positive or negative?
And ApoE4 positive or negative. Now, interestingly,
Really?
for the ApoE4s, what we typically suggest, and this was actually originally suggested by Julie G., who started the website, apoe4.info, you essentially start with using the MCT oil to help you get your ketosis, but then switch after a month or two to more monounsaturates and polyunsaturates. Now you can essentially balance, so you have the best of both worlds. You follow your LDL particle number, your LDLP. You want to keep it below 1,000. So you can adjust how much MCT oil and how much of the monounsaturates and polyunsaturates, so that you have the best heart outcome, the best cardiovascular outcome, at the same time have the best cognitive outcome. Be careful if you don't get your ketones up and you get your carbs down, you're starving your brain. And so then people will say, my gosh, I just have no energy. Right. So you want to use that. You want to basically be changing over to a more ketone-based metabolism for your brain. And then, as you indicated, you want to go back more toward the monounsaturates and polyunsaturates to make it heart healthy.
So for this, the ApoE4 positive people, you do recommend lowering the saturated fat intake because of
after
the LDL.
After you become insulin sensitive. Okay. So after you want to drive yourself into insulin sensitivity, so you're able now to convert. So because it takes a few weeks, as you know, to convert from a largely carbohydrate-based metabolism to a largely fat-based metabolism. So if you try to do it in a day, you may end up with so-called keto flu. And it takes some time, and you're now producing. It's a whole set of things you're producing. It's going to be less inflammatory. You're lowering your reliance on glucose. You're becoming metabolically flexible, and you're now essentially developing a use of the ketones. And it just takes a few weeks. It's helpful to do things like exercise and things at that time to help you convert.
And then the overnight fasting of at least 12 hours is, or like you said, if you're ApoE4 positive, possibly even increase that to 14 hours. Right. That's interesting that you're talking about, while you're sort of transitioning into the becoming more ketogenic, that you may actually have to increase your saturated fat intake because you have to really. It is kind of hard to go into ketosis without really just having a lot of fat.
That's right.
And so it's something I have not experimented with yet. I found out I had an ApoE4 allele, and so I've definitely become extremely interested in Alzheimer's disease and what I can do to prevent it because, as you mentioned, not everyone with one ApoE4 gets Alzheimer's disease. It's a very complex diet-lifestyle interaction. At least
and no one should.
Yeah.
And that's the key. This should be largely ended with the current generation. Everybody should get checked. Everybody should get an optimal personalized program. That is the medicine of the 21st century.
I wanted to ask you about this because a colleague of yours, Dr. Eric Verdin at the Buck Institute, I spoke with him a few months back on a very interesting paper he had published. I believe it was Cell Metabolism, where he had given animals a cyclic ketogenic diet, and there was just improvement in health span in general. Right. But what was really, really robust was the improvements in cognitive function and brain aging, where it was just hands down like clear that that diet really helped delay brain aging. And so of course those weren't ApoE4 positive mice, but
this is the exact same thing we're seeing with people, and especially people with early cognitive decline. Now, as you go later and later, it's more and more difficult, but we have seen people even with MoCA scores of 0 show improvement. So yes, I think the work that you quoted supports that notion that in fact having ketones is actually quite helpful for cognition.
Do you think, and here's a couple of questions related to that, and that is, is that probably multiple things, but one, because you're obviously going to have improved insulin sensitivity. You're not going to have high blood glucose levels and all the inflammatory processes associated with that. Yeah. Also, the ketones, as you mentioned, are used by the brain quite nicely. Yeah. And interestingly, it actually spares. Are you familiar with the glucose sparing? What happens with so glucose gets spared to make NADPH, a precursor for glutathione, so that helps repair damage. But I'm wondering, if people, like myself, I don't really practice a ketogenic diet, but I also don't. I eat a very healthy diet. I definitely try to, make sure I don't eat anything refined, no refined carbohydrates or processed foods or things like that. Right. The thing is that my fasting insulin's really good, and my blood glucose and all that's really good. So for me, going on a ketogenic diet, do you think there would still be more benefit, even though the whole, insulin sensitivity thing, maybe it would still improve. I'm not sure.
Yeah. Well, I think the only way you're going to know is to try it.
To try it, yeah.
And you can even do all sorts of online evaluations for your own cognitive ability. I do think that many of us are suboptimal in our metabolism, and we know this. One of the problems, of course, is that there have been a lot of assumptions made during the 20th century. Yes, it's fine to have processed foods, it's just as good. It's fine to have more sugar, on and on and on, which just simply have turned out to be wrong. It has to do with sleep, it has to do with exercise, all sorts of things. We were built as human creatures to do certain things well and to do other things we weren't built for. If we all were jumping out of third-story windows as something to do that would be fun, that would not go over well for us. And to some extent, we're doing the same thing with the way we're living. So obviously, you've managed to stay fit and to have a good fasting insulin and all these sorts of things. However, a little bit will depend on how, what you're actually doing. For example, do you have, where is your hemoglobin A1C, for example? Is there some inflammation there or not? The bottom line is that we were not made as human organisms to consume the amount of simple carbs that we typically are exposed to. So to some extent, just as we're being exposed to all these other toxins, of course, sugar is one of them. And whether you try to be exposed to it or not, often we are exposed to it from all sorts of different foods and things like
Going
that.
out to eat, you never know.
Going out to eat, you don't know what's in there. And look, there's also the whole issue of leaky gut. So many people, this wasn't even known as a problem when I was in medical school, but it's become very clear that it's very common. It does contribute to chronic inflammatory conditions like arthritis, and like cognitive decline. So I think that having a high-fat diet has been helpful for many people. But what you can suggest is, look, if you ever have any cognitive decline, get in as early as possible and then consider this. In your case, of course, as you indicated, you're interested in prevention because you already know that you're ApoE4 positive. So it might be worth trying it just to see. But obviously you're doing a lot of other things right currently.
And measuring a lot of different, other cardiovascular rated biomarkers is also good.
Right.
So you're going to measure things like LDL particles number and size and triglycerides and all those things as well.
Exactly.
To make sure that the changes you're making are actually indeed good for you. I think that's very important.
Absolutely.
So the diet and then exercise and the sleep is really important. You mentioned the lymphatic system. There's, to my knowledge, really, is there two major ways that amyloid beta plaques are cleared from the brain? One is the lymphatic system.
Well, of course, there are multiple. There's the ratio of formation to clearance is critical, and of course, you're going to be forming more and keeping more if you actually have a state of inflammation or of responding to a pathogen. So there was a really interesting test developed by Professor Milan Fiala at UCLA, developed about almost 10 years ago now, and what he was looking at was taking peripheral blood mononuclear cells. So you're essentially taking the blood macrophages, and you're now simply challenging them. He would give them amyloid and just look to see how good are they at phagocytosing, at eating and getting rid of the amyloid. And the surprise was all the people who have Alzheimer's are very poor at eating and getting rid of this amyloid. It was as if they're literally trying to keep the amyloid around. And we realized, this is a state. So, as you know, it's become clear that your cells change states. You have the metabolic flexibility. You have burning this and burning that for fuel. One of the states, you change back and forth between a pro-inflammatory state, essentially an NF-kappa B mediated state, and on the other hand, an anti-inflammatory, a state that is involved more with SIRT1. These two actually have multiple sites of mutual inhibition. So you're literally flipping back between these different states. And the people who had cognitive decline are poor at getting rid. They're literally keeping this amyloid around. And if he looked at their M1 to M2 ratio, so essentially inflammation to resolution, he saw two patterns. The people who don't eat the amyloid and who have the cognitive decline either have a pro-inflammatory state where they have a lot of M1 and very little M2, or he found that they literally had an atrophic state, the same thing we saw as type 2, where they simply could not produce enough of this to resolve. So they literally have very low levels. And so in fact, getting the right level, about 2.5 to 1, was associated with the best outcomes. So you do have this phenomenon, and so yes, as you know, you've got everything from insulin-degrading enzyme, neprilysin, macrophage clearance, lymphatic system, I mean, on and on and on. There are multiple ways. But as long as you're in that state where you're using multiple mechanisms to keep this stuff around, you're not going to be very good at metabolizing it.
Mm-hmm. This paper that you're referring to, I do remember reading a paper that you had published a few years ago, where you had taken this, essentially, I guess you can use it as a biomarker, right? If the people with Alzheimer's disease are not clearing amyloid beta plaques via phagocytosis with their monocytes effectively, that's sort of kind of a surrogate marker for what's going on in the brain potentially, right?
Right, and this is Professor Fiala's test.
Right. And you had done a small study where you had given people some omega-3 supplements along with some antioxidants and vitamin D, and it improved their phagocytosis of the amyloid plaques in the periphery, and also I think their cognition. Some individuals had improved cognition, ApoE4 negative ones.
Right, and so that was, so I was a co-author on that paper with Professor Fiala.
I see.
So again, he invented the test. And he's now doing, the small number of things that you described there. What we're doing is a much larger set where we're doing more of a program, but clearly that is an important part of it. Mm-hmm. And of course, Professor Sirhan from Harvard has shown that resolution is a critical part. You have the inflammatory part, but then you have to have the resolution part. And if you don't have that resolution part, again, a change in mode, then you're stuck with this chronic inflammatory state. And so things like omega-3s and omega-3 derived myrcins and things like that are actually involved with the resolution, resolvins, for, named for that very event.
Of resolving inflammation.
Right.
I remember in that paper, and as I've also done some reading on this because I have a paper that hopefully will be published quite soon on ApoE4 related Alzheimer's disease, and particularly with respect to omega-3. So there's some evidence that for whatever reason, fish, when people that have ApoE4 are given fish or eaten fish, they're protected against Alzheimer's disease. But DHA supplementation, it's not the same, at least for ApoE positive individuals. And it's kind of been a mystery, as to why that is.
And by the way, Professor Paul Clayton from Oxford has discussed this numerous times and written about this. And his argument is that, of course, fish have much more than just DHA and EPA and things like that. So they have antioxidants, things like secoiridoids and things like this, whether you find them in plants or animals, that actually are protective. Because you have to remember, you're looking at something with multiple sites of desaturation. So it's very sensitive to oxidation. And so, you have to protect that. And you're absolutely right. This idea that we had in the past that, fish, hey, it's just as good just to get that oil out. It's not just as good. And although the oil can be helpful, you better make sure that it's not oxidized, and better to get it in its appropriate setting.
Very interesting. Some interesting papers had come out from a few labs. One from Salem, Norman Salem, sorry. He had shown in animals, if you take animals and give them human ApoE 3, 4, 2, that there was and then feed them DHA orally, there was a transport defect in DHA across the blood-brain barrier. And so I kind of reviewed this work and a variety of other papers as well, talking, where there's a couple of major mechanisms by which DHA is transported across the brain. Are you familiar with some of those? One is through a free fatty acid, and the other one's through an actual transporter called the MFSD2A transporter, which is actually in a phospholipid form. DHA is in a phospholipid form. And so it appears that there may be different ways that these, that DHA gets across the brain.
Right.
And one of the ways is potentially not working quite as well in ApoE4 individuals. At least that's my theory. But once paper's accepted, I'll send you a copy.
Thanks.
So it's super interesting.
Yeah, and of course, as you know, Professor Wertman from MIT has spent years looking at what does it actually take nutritionally to make synapses. And his point was you need the DHA and you need acetylcholine as well. And so again, if you're going to be helping people to change that balance toward the synaptoblastic, you want to make sure that they have plenty of those precursors as well as the appropriate signals, reduction of inflammation, all these other things that are actually part of an overall orchestrated event.
The other interesting thing is that DHA, and I didn't know this previously until I'd been digging into the literature, is also seems to be important for some of the glucose transporters on the blood-brain barrier. And so if you're DHA deficient, those glucose transporters aren't working as well, and you're not getting glucose into the brain, which is another real hallmark of Alzheimer's disease.
Absolutely.
So that's another interesting thing. So the other a couple of interesting things I wanted to ask you about were kind of off topic, but not particularly. You mentioned this type 3 subtype. Would the herpes virus fall into that?
So so herpes virus could give you type 1 or type 3 depending on what you're actually responding to. If it's just a chronic inflammation, then it would be a little bit more like a type 1 with chronic inflammatory. But you're right. Again, many groups have said, okay, it's about herpes. Okay, it's about P. gingivalis. It's about Fusobacterium nucleatum. It's about Candida. And the reality is all of these are capable of inducing the signal, this change where you're making the amyloid as part of a protectant. It's part, as you know, it's essentially part of your innate immune system. So if you're responding in that way, it can be any of those things. It's not just one every single time as far as anyone knows. So yes, you alluded to the recent work on herpes, and especially, of course, 6 and 7. And so yes, not surprisingly, one of the things we see frequently with the various patients is chronic exposure and chronic presence of the various herpes family viruses, CMV, EBV, HSV, HHV, all those things.
The last thing I kind of wanted to mention, just because I wanted you to know about it in case you weren't aware of it, there's some really interesting research coming out of Finland. Are you familiar with the saunas and the protective? Oh,
yeah, of course.
Okay.
Yeah, dramatic effects. And,
yes, very interesting.
Fits very beautifully with everything we've been talking about. And certainly, what happens when you have a sauna? Yes, you may induce some heat shock protein. Great, that's important and can be important in folding of proteins. But what also happens, of course, is that you detox. And these people who are doing this repeatedly, some nice work by Dr. Genuis from Canada, who showed that if you look at composition of sweat compared to the blood, there are certain toxins that are very high, cadmium being the big one, over 1,000 times increase in sweat. So a good way to get rid of cadmium, but a good way to get rid of other things
Mercury
as well.
Right?
I think you're right with Mercury.
BPA
but
comes out of
BPA,
the sweat.
especially the hydrophobic toxins, the non-hydrophilic stuff tends to be very good in the sweat. So, but others as well. And so that's why it is very helpful, and many of us don't do enough of that sort of thing. And as has been pointed out, whether you're doing it through sweat and exercise, or whether you're doing it through saunas, whether you're doing it through other mechanisms, yes, it's good to get. And then you want to use a non-emollient soap immediately thereafter, things like Castile soap or whatever you like that's non-emollient, and get rid of this stuff so that you don't get repenetration.
Yeah. The other thing is the cardiovascular effects on with the sauna, and that may also be related to
Absolutely.
to dementia as well. So is that something that you'd consider using in your protocol?
Oh, it's part of the protocol.
It is part of the protocol.
Oh, absolutely.
Excellent.
No, we recommend that people, and especially if someone has type 3, that's even more important. But as a general rule, part of this is, as my wife says, resilience. Part of this is resilience. We're taking people who are suboptimal in their metabolism, in their inflammation, in their toxic status, in their lifestyle status, in their sleep, in their stress levels. These are surprisingly important. One of the first people who came through was a very intelligent physician. And as we went through each thing, he said to me, well, I don't believe that's not a cure for Alzheimer's. That's not a cure for Alzheimer's. He had well-documented early Alzheimer's, PET scan proven, amyloid PET positive, FDG PET positive, hippocampal atrophy, the whole 9 yards. And as we went through each thing, he was telling me, well, I don't believe this, and said, look, this is not about one thing. This is about a program that is optimal for you. Mm-hmm. And actually, he's done extremely well, and he's now 4 years into the program and still doing very, very well. So it is about changing signaling within your synaptoblastic to synaptoclastic ratio, providing the right support for that, DHA and acetylcholine and vitamin D and appropriate hormones and BDNF and all these things, and making sure that you don't have chronic exposure. And as you mentioned, sauna is actually a very powerful way to help reduce overall toxic burden. It is surprising how much toxic burden most of us are living with.
So talking about, how the importance of, intervening in multiple ways, because there's so many different pathways that lead to inflammation, that can lead to insulin resistance, that can lead to toxic burden. Right. One of the really, something that's made major headlines over the past few years is the failed clinical trials targeting amyloid-beta plaques.
Right.
Multiple clinical trials. I mean, it's just one after the other. So.
And actually, we've had a number of people who have tried to remove their amyloid with antibodies who've actually gotten worse with that happening. So you have to go back to why is it there? And it's tough because, yes, it is both part of the mediator. It's not the cause of Alzheimer's, it's a mediator. And I think that's been one of the problems. People want to say it's the cause. It's a mediator, and there are many upstream things contributing to that. So on the one hand, it's a mediator of the pathophysiology. On the other hand, it's also a protectant. It's a response to things like pathogens. And so there's a double-edged sword there. It's fine, I think, in the long run, it'll be fine to remove the amyloid, but you've got to remove the cause of it first. Now, of course, people have just tried to go earlier, and can we actually see some improvement? So I think it won't be surprising if you can get a little improvement early on. But again, it's a little bit like saying, if we fire the CFO, we can all spend a little more for a while. Well, if we're still going to go into the red, we want to know, we want to make sure that we're spending for the right things. We want to know why your amyloid is there to begin with. We want to remove all those things, then remove the amyloid, as opposed to just blindly removing this mediator and leaving the various inducers.
Right, right. And with Alzheimer's disease, it's so, there's, as you've been talking about for the last hour, there's so many different things that can lead to it, so many causes, so many things in the environment, in our diet, things that are not present in our diet, that it's difficult to just find that one monotherapy and target it, And things are always much more complex. Like it seems like, well, amyloid plaques in your brain, of course you want to get rid of those. They're destroying synapses, and well, as you mentioned, it has a function. It has a really important function. And for the longest time, I remember I was trying to, this was some years ago, I was trying to understand what the normal function of amyloid beta, even amyloid precursor protein, like what is it doing? Why is it there? Like obviously we have this whole elaborate system. We have these enzymes that cleave it in this right position, and it forms this, 42 amino acid fragment. I mean, that's all happening for a reason. It's not, it doesn't seem like it would be programmed into our biology to happen, to cause dementia. Yeah. And so I think it really is important to understand what the normal function is of the amyloid beta, and also with the tau, phosphorylated tau and tau protein as well. Is that something that you find quite often in the people that have the amyloid burden and are affected, they often also have tau tangles in.
Oh, yeah. It's now, tau imaging is still kind of in its infancy. So most people we don't know. So, they may have an amyloid positive scan, but they haven't had a tau scan. However, they are clearly in Alzheimer's. And I say we do know that many of them do from cerebrospinal fluid. So these people that we've reported, I mean, these people have the low ATI that is associated, amyloid tau index. So they have the low A beta 42s in the CSF, and they have the high phospho-tau and total tau in the CSF, the ones that have been evaluated. So indirectly from that, we can say they definitely had tau. They're likely to have phospho-tau tangles. And again, if you look at what this is doing, it makes a lot of sense. When you are trying to pull back on a connection, then you need to collapse the superstructure. And what does the phosphorylation of tau do? It allows it to pop off the microtubules, so you have a rapid collapse of the structure. So no surprise, when you're in this mode of you're trying to fight this off, you're trying to change, you're trying to pull back on your structure, you're going to phosphorylate your tau, pop it off the microtubules, and you're going to die back, and that's exactly what you see. Right. So again, it's not that the tau is not the cause of the problem. It is a mediator based on what's going on genetically, with pathogens, with toxins, with metabolic changes, with innate immune system, and with trauma. So the things that are driving this are the things that we want to target.
What percentage of people would you say is it more common to have your subtype 1, 1.5, 2, the inflammation and insulin resistance and the neurotrophic? Are those the most common, would you say, types of Alzheimer's disease?
This is a really good point. So initially what we saw was that many people had this type 1.5. Glycotoxicity is so common. In fact, again, Professor Getzel from UCSF had a nice paper a few years ago showing that everyone he evaluated using exosomal analysis had the signature of insulin resistance in the nervous system, whether they had it peripherally or not. It was really striking.
Exosomal analysis.
So this was exosomes that he analyzed, and specifically he selected the neural exosomes, which represented about 10% of the overall exosomes, and showed that they all had the signature. This was this change in phosphorylation of IRS1. So clearly that's a very common thing. But what we're finding is rarely do people have purely type 1.5, 1 or 2. So although type 3, this toxin type, represented only about 15 or 20% of all of them, that's the pure, over 50%, so typically in the 60 to 70% range, had at least some suggestion of the type 3. So in fact, most people have some sort of toxin exposure, pathogen exposure, that sort of thing. So so what it's turning out is that it's more about what's your mixture. Are you predominantly the type 3 with a little mixture of 1.5? And by the way, the easiest to deal with, type 1 and 1.5, you can improve that, as you can imagine, with things like resolvins. Inflammation and glycotoxicity, you can improve with diet, exercise, sleep, stress, stuff like that. Improving the atrophic is a little harder. You've got to get all the right things. Many people have to go on bioidentical hormone replacement. You've got to optimize the support for your brain. And then the hardest of all is the type 3, because you're having to find out, for example, some people have very high ERMI scores, that's EPA relative mold index. If you've got mycotoxins being produced and you're living in them, you need to get out of there. Or if you're working in them, you need to get out of there. And until you do that, you've got this chronic exposure.
Is there a test people can do to see if they've got this type of mold in their house?
There's an easy test. In fact, you can go on, the government has set up this so-called EPA relative mold index, and you want to get a score that's less than 2, again, as Dr. Shoemaker recommended years ago. And you can easily get it, go on mycometrics.com. They'll literally send you some little cloths, and you can go around and take areas that you are concerned about, send it in, and they will actually do by PCR analysis, looking for evidence of these various species. And if you've got species that happen to produce a lot of toxins, it's a concern.
Wow.
Then you can actually measure the toxins in urine tests. So you can get an idea. And then again, you can actually see with your detox.
Is that a consumer product that you can get?
Yes, you can. Yeah, you can get. There are a couple of companies now that do make urinary mycotoxin tests.
Okay. And so for people that don't, let's say they don't have the toxin exposure, or they don't think they do, but they don't. If they've done this test, the things that they can do in their diet and lifestyle to prevent the Alzheimer's disease would be the major things to reduce inflammation, which are a lot of things: diet, lifestyle, exercise, sleep, and then again a lot of overlap there with improving insulin sensitivity and fasting glucose levels and all that.
Getting your hemoglobin A1C down, all those things. Perfect. Getting on a plant-based. And by the way, you probably know that Dr. Terry Walls has published a lot and actually has done a lot of studies now on using a similar sort of approach for multiple sclerosis, and has seen excellent results, including in herself, with taking this sort of an approach. So again, looking at the drivers and looking at what are we actually responding to, and are we having more of an autoimmune response like with MS, or are we having more of an innate immune system response with Alzheimer's? These are critical for dealing with these complex.
Do you look at markers for gut health? Because you were talking
Absolutely. I mean, gut health is one of the most common things.
I mean, inflammatory markers, or is there like an actual marker for gut health that's more direct?
Oh yeah. So there are a couple ways to go. There's a Genova test, a doctor's data test. There are different tests that are like stool analysis sort of thing. But you can also do Cyrex, for example. So Cyrex Array 2. Cyrex has a whole set of different markers for different antibodies. So if you have a leaky gut, you're often going to respond to things like LPS coming from your gut. Then there's a Cyrex Array 3 that looks at various of the domains of gluten and gliadin. And so you can look at that. And then there are various autoantibodies, et cetera. So yeah, these are very helpful to know.
Can you spell Cyrex?
Common. Yeah, it's Cyrex is the company that developed these.
Excellent. I haven't heard of that one.
Yeah,
so for the Genova diagnostics, is that the metabolic metabolism test, or is there a gut one?
There's a gut health one specifically.
Okay.
GI effects.
And
then and Dr. Aristo Vojdani is the one who developed these various assays for Cyrex that are now being used by the Cyrex company.
And that's
excellent
consumer
immunologist,
well.
and that's available. Yeah.
Excellent. I'll definitely check those out.
So the reality is, it's an era in which, just like you're going to take an Uber, for example, you don't necessarily have to call a taxi anymore. In this era, we can actually get a lot more data. The quantified self is becoming more and more popular and more common. And it's something, to some extent, the responsibility for our longevity and for our health is resting more and more with us. If you want to learn more about the protocol, please go take a look at the book. And it's called The End of Alzheimer's, and from Random House. The other thing you can do is you can go to the website, drbredesen.com, look at it there. And we are responding to, there are a lot of comments on the first book that is coming out now in 26 different languages, a lot of comments saying we want more specifics about, what URLs do we use, where do we go. So we're actually now putting that in a second book that will be out next year.
Excellent. Well, thank you so much for this conversation, Dr. Bredesen, for your wonderful research.
Yeah, thanks very much, and good luck with your work.
Thank you.